Dr. Redmond, I want to go back just a minute. You're probably, I think, going to get to it. You were talking about studies.
Right. There's a study here. Now, again, if we can take a little break from the questions, this will probably cause even more questions. I'm happy to answer them. And I am a bit of a contrarian. I like to challenge what people think. But when you're looking at studies, I get people come in all the time and say, Doc, this is proven that this is the best. And I'm like, well, you know, I didn't see that study. I'll go back and I'll look. And it'll be a single-arm study, which means there was no control group. It had maybe 100 patients in it. And it's a retrospective study. Those studies tell you nothing about choices in prostate cancer. For a study to be worthwhile to affect how I practice medicine, it has to be randomized. It has to, in other words, there's a flip of the coin involved. And it's very difficult to convince people to, you know, consider if you came to me and I said, you know, one third of the coin is going to send you to surgery, a third of the coin is going to send you to the linear accelerator, and a third of the time you don't get treated. Now, you got to be a special person to accept that. I think I could, because that's kind of my belief system in medicine. So it has to be randomized. It has to be multi-institutional. You can't just have it all coming out of one institution and say, this applies to everybody. It has to be spread out. So those are usually randomized trials run by government agencies or groups of governments or groups of countries. In Europe, they group them together. In the United States, it's Sussex. If it is a randomized study, and for it to show anything, if there's 2 randomizations, you have to have at least 250 people in each arm. Statistically, it won't tell you a thing. If it's 3, like this one we're going to talk about, you need 500 people here. And I need 10 years of follow-up. Because otherwise, it's not telling me. Because all the questions you guys are asking, it's like, I can tell you, you can walk out here and not be treated for low-risk prostate cancer. For the next 10 years, you're going to do great. But that's not the answer you want. I want to be great in fun, Mike. I would too. So let's talk about the study. So this is a study that came out of the New England Journal. Now, why is that important? Well, they don't have an axe to grind. This is not a radiation journal. This is not a urology journal. You know, and this is the epitome of American medicine. If you get the New England Journal, they have vetted it very well. So you can really trust what they do. That being said, sometimes bad stuff gets out. So this was this was a group of, and this was done in England. So if you say, what don't you like about the study? Well, it's English. So a lot of times we Americans say we only accept American studies. I have to watch that. I have a son-in-law who's English now, so I can't say that real loud. But he's up in Columbus. I don't know so we have a different genetic makeup in this country. So you would have to ask, how many African Americans were in the study? So this may apply to a more homogeneous population of English people. Now the English have, you know, they're multicultural too, just like us, but you don't know. And since I wasn't participating in the study, I don't know the people who did it. That's something you have to keep in the back of the mind. But they reported 10-year data. So it was a study where they basically randomized people to surgery. And the surgery was the surgery they did 10 years ago because they had 10 years of follow-up, right? So they probably weren't doing robotic prostatectomies. The radiation was radiation 10 years ago. Everybody on this study got 3D conformal. Well, and the Cadillac was more like the Chevy, not quite the Yugo, but the Chevy. So it was what they were doing in England. And the watchful waiting was based on, and we'll define active surveillance watchful waiting. They had certain criteria that they would come back and ask, if you're randomized to no therapy, they would check the PSA and they would say, if it goes up, they say, are you sure you want to stay on this? Because they would let you bail into something else, but they would follow you just like you were on active surveillance, and that brings up a lot of interesting questions. But when I saw the study, I was like, wow, it's too bad we couldn't have done this. So it was for PSA detected patients. So they're trying to answer this question. If you detect a prostate cancer by PSA, do we have treatment choices to make this whole screening thing worthwhile? And they also did a very good side effect severity, and they looked at urinary, sexual, bowel function, and they had a very standardized questionnaires that everybody answered. So you could tell, okay, this is what you're getting with radiation. So first, we're going to do it backwards. This was a companion study. It was published back-to-back articles in the journal. We're going to talk a little bit about the side effects first. So this is for urinary function. And just the code stays the same in all these graphs I'm going to show you. So the red is radical prostatectomy, the yellow is radical radiation, and then the blue is active monitoring. And you will notice, like everyone in this room probably already knows, that if you're a radical prostatectomy, you're always a little worse on the quality of life, the side effect profile, whether it be they had an incontinence score, 1 pad per day. They had all sorts of, and they didn't rely on just one quality of life assessment. They used the best ones that they could find. So yeah, so that kind of proved what we kind of think we know, unless you're wrong. And this is erections. This is probably the most important one, because this is the question I get a lot of. So if you have, this one is erection firmness, erectile dysfunction is the score, sexual function score, sexual bother score, all sorts of these things. And what consistently comes through in all these things is that if you look at what is worse, it tends to be the red. And so, but not by much. And radiation isn't that far behind. So it's basically, again, confirming what I thought I already knew, was that, and if you look at, as it goes out to 5 years, it looks like those treatment curves are coming here. But the watchful waiting guys didn't do great either. I mean, there's a natural attrition of erections as we get older. And so, but that's the data. And when's it going to come up bad for radiation? If you talk about the bowel, the radiation scores were, and this is probably the one I noticed, is bloody stools. Now this is 100%, 67, 33. I don't know exactly. That's about 10%. So the people that I radiate, 10% of them are going to have some blood streaking in their stools. Now usually it's well controlled. Usually it doesn't lead to anything more than that, but it can be a bother. And it's a little higher than what you get with the other two. And if you look at the bother score, which is like loose stools, when I treat somebody, I tell them to expect that their stools will get loose, they'll get a little mucousy, and that should get better. And 90% of the time it gets better all the way, but I have to tell them, sometimes it won't. So this is kind of confirming everything that I thought I knew, but it's something that you can show patients. Now, this is an interesting one. They have a physical health score, mental health score, an anxiety index, and a depression index. And they all look pretty similar, but the people who select no treatment are a little bit more anxious. Even though you can tell them it doesn't make any difference. We think you're going to have the same result in 10 years. They're more anxious. Then maybe that should tell you, what you should select. This is the best data that we have. And it's what we thought, but it's when you're going to someone and you're saying, well, I think this is right. Here you can say, this is what observation of 500 people shows. And again, you could argue that all modalities are a little better, but that they're all probably going to be in this range. And this just kind of shows all the quality of life they use. So this is they went back and they looked at some of the other studies that compared treatment to no treatment and tried to say, is this consistent with what we found with people who didn't have treatment versus prostatectomy or radiation? And in the people that had had prostatectomy, the incontinence scores were worse. In people who had either radiation or surgery, erections, they started out bad and they got a little worse. So the pivot is probably the one that before this had the best, and that was a randomized trial that looked at radical prostate. It's an old study, so it's old surgery versus follow-up. And that was the one that started out saying, we don't see survival differences after a certain age. So the conclusion was that basically this is what we saw, and it was a companion study. But I think it's interesting just to kind of go over all those things, and so know what can you expect. So I had to put this up. I see this every day when I drive home. I am an Ohio State Buckeye. I grew up going to Ohio State football games. I went there undergraduate. I've seen the monstrosity of the beautiful hospital go up, paid by government money, and I see this, maybe a half mile from my home. There is no routine prostate cancer. Well, I'm going to go over the study. I'm going to argue there is a lot of routine prostate cancer, and I think this is one of the things I think I have to worry about, and doctors have to worry about, is that there is a tremendous financial bias to treat prostate cancer. It is huge. You don't pay for a big hospital unless you treat a lot of patients. You don't run a proton center unless you can break even. That could be the white elephant all times. So there's a tremendous pressure on doctors from bean counters to say, why aren't you treating more patients? Mm-hmm. And I said, gee, Dr. Redmond, you saw this patient and he came looking for proton treatment for prostate cancer. And I said, yeah, I talked to him. I couldn't convince myself or him that it was a good thing to do. Well, I guess I hope I have a job the next day, but you don't know. There is pressure. And to think it isn't there, I think, is a little bit naive. I always tell because I tell residents this, and they think, oh, we wouldn't be affected. And I said, every time there's a group of doctors saying that financial things don't affect how they treat, somewhere there's a room of health economists laughing their asses off. I mean, you got to be kidding me. We've got data. That it just doesn't happen. And I said, it's kind of, you remember when you're growing up and you rooted for your baseball team, and all of a sudden they could go wherever they wanted. And you're like, oh. And the guy said, I really love your team, but this situation is just so much better for me. I really like the manager. It's not about the money. And no one laughed. Well, now everyone knows it's about the money. Money is it's a part of life. And I'm not saying it's an overwhelming decision on doctors, but it's always there. And I'm all for doctors, driving fancy cars and having vacation homes and doing all that good stuff. But I got to do it knowing I'm doing something good for the patient. And if I can't really push it. And I've got all my kids through college. I'm going to retire soon, so I can talk like this. But the other thing, I joked to Bill Barrett. I said, Bill, there is a billboard. It's right. I go by it. When I go home, I grew up in Burlington, and I go right up 315. I go right by the hospital, and there's this big billboard. And I say, can I buy that billboard? And say the best radiation therapy in the state of Ohio is right down the road, 80 miles in Cincinnati. He goes, no, you can't do that. And I said, darn.
Didn't they give that to the urology group? They had a billboard up on...
Oh, it's all over.
Yeah.
They are all over the
Close to
place.
UC, very close to the UC.
Oh yeah, they were very strategic where they put those,
Okay.
and they need patients.
I have a question.
Yeah.
You told us you went through the study, but both the treatments have gotten so much better, and one treatment might have gotten a lot more better faster than the other treatment got better.
Yeah, might.
I mean,
You don't know, but every time we have looked, we tend to get the same results. So, if every time you look, and these studies are immensely expensive. To follow a group of 1,500 guys for 10 years is millions, tens of millions, 20 million. It's a huge expense. So you can't do these. It's not like you can do it every time something changes. And before you know it, something changes. In 10 years, we're going to have some sort of improvement in radiation. There's going to be some improvement in surgery. What do you just stop all the studies and say, okay, we're going to go back to school? You never get a study done. So I want to get through this before you guys get totally...
Real quick, Dr. Redmond, the big thing on that study, besides all the side effects and all that, was that the mortality rates were almost the
Give me a
same.
second. I told you I was saving the best for last. You're stealing my thunder. So the best part of the study was this. It was called Protect-T. It was done in Great Britain. It was 1,600 men. PSA detected prostate cancer. It was local. Most of it was low risk. They didn't define it like that because they define their prostate cancer differently in Great Britain than we do. And this is what they did. They had 1,600, a little over 1,600 guys that underwent randomization, about equal number in radical prostatectomy, radical radiation therapy, and monitoring, okay? And then some guys, they got randomized, and they said, no way. I thought I was psychologically ready for this randomization, but I couldn't do it. But pretty good numbers that were randomized. In the radical prostatectomy, out of 500, 400 had the surgery within 9 months. Some just changed their mind with radiation, and then same thing. So there's always a little messiness in this, but statistically, to make it pure, you have to. It's called an intent to treat study. So however you were intended to be treated, however you're randomized, they followed you. This is a very interesting slide of people who underwent radical treatment. So if you were randomized to radiation therapy, over 90% got it. And they got some sort of active therapy. Same thing with surgery. In the active monitoring, this is very interesting. They got it, and that they could break away from the active monitoring group at any time. So at the end of 10 years, over half people, I say, got beaten down and said, okay, you better treat. Do we know when's the right time to activate treatment during active monitoring? The answer is, I don't think we do. One of the things they found about the study is everybody did very well. That's a prostate cancer specific survival curve at 10 years. Hardly anybody died of prostate cancer, no matter how you treat her. And this is important because I think you have to think time frames. So people say, what's going to happen in year 11? Okay, I don't know, but we're going to follow this group out. Now, freedom of disease progression is interesting. The active monitoring fell off a little bit, but that's because they define disease progression as changes in your PSA. I guarantee you the people that I follow for prostate cancer, their PSA slowly get worse. And it's a rate phenomenon, and when do you pull the trigger? So you could look at this slide and say, hey, look at 60% of the guys, they should have gotten treated right up front. And I look at it, I think their indication for pushing people from active monitoring to treatment might have been a little bit too severe. But I think they erred on everyone wants to err on the side that they don't. This is a gradual change. You don't want to err on the side of not saying people like, I'm going to dissuade you not from having treatment. But I can tell you that if you're monitoring somebody, every time you get a PSA, there's a little deep breath, you worry about it. It's like you have to make a decision every time that you're not going to be treated. And eventually, some people decide, I just don't want to do this. Yes?
Is there any accommodation for Gleason scores in this?
Oh, we'll get to that.
I'm sorry.
Sorry, yes?
Just one question. If you don't get a PSA, never get a PSA, what are the symptoms that you have prostate cancer?
Well, you may have urinary problems, but usually not. You may have a palpable nodule on your prostate.
I mean, the guy can feel it.
Yeah.
There's a prostate exam.
Yeah.
That's it, huh?
Mm-hmm. So, I guess people got to call me blissfully ignorant if you want to.
No, I'm just trying.
But no, you have to accept that. You have to accept that you're never going to know, and there's no evidence to show that knowing makes a difference.
If it does anything different.
Right. Oh, oops. What did I give you? Another question. Yes.
If a person had high-grade prostate cancer,
That's
what
different.
are they?
That's different.
Okay,
That's
what
totally
is
different.
the outcome for that?
There's a dividing between what we call that. If you look at prostate cancer and how they try to assess risk, there is low risk, and then they find something that's very low risk that's relatively new. For people who just like, I don't want to follow prostate cancer, but I guess there's some people who can follow, so we're going to make this risk very tight. There's intermediate risk, and then there's high risk. High risk is basically a Gleason score of 8 or higher. Gleason 7 straddles depending on how people break it down, but it's where your PSA is. So if you have a Gleason score 7 and a PSA less than 10, that might be a lower risk. They have low intermediate risk. If you're above, maybe higher. There's all sorts of ways you can kind of parse this out. And the other thing, I'll throw another editorial comment out here because Tom smiles every time I open my mouth and I do that.
That's great stuff.
Did you ever wonder where the Gleason 5s went?
Oh,
I remember, I'm a dinosaur. I remember when those roamed the earth, but those are extinct now. So why is that?
They quit counting.
Because Gleason score is a subjective measurement by a pathologist. What influences a pathologist's thinking?
Lawsuit.
If I call this something that doesn't have to be treated, and they die of it, I could be in trouble. If you don't think that is something that makes them, this is a 6 or 7, I'll push it to 7. So I personally think, in my experience over 30 years, that there's been a Gleason score inflation. that you know why, and I'm not sure that prostate cancer has changed, but that is a very subjective measurement. And I'll say something I probably shouldn't say, but if I have a pathologist reading my slides, I don't want them to have any skin in the game. I don't want them to be beholden to a radiation therapist or urologist.
Well, we always say send our slides to Johns Hopkins for a second.
Right. They don't care what you pick. They know you're not going to come there for radiation therapy. You may come there for surgery. But yeah, they're and those people are not paid, you know, however you want to call it.
Incentivized.
So urologists sit
Not
in
on
the business,
commission?
is what you're saying.
Well, one of the things I found out when I was doing prostate implants, I would always be in the same room with the residents, urology residents. And whenever they were getting close to going out to work, they would get a little cocky, and they made it through, and they were going to go out and earn their living. And the phrase that always kind of made me chuckle was, there'll be a couple of them together, and I'd be over here, and then the guy goes, "Yeah, I'm joining this practice. You eat what you kill.
What?
You eat what you kill." And that was their way of saying, if I do something, I get paid.
Oh, really?
Yeah, that's how doctors
That's
are.
what I'm through.
That is probably what people say is the biggest problem with American medicine is we have very perverse incentives on what we do. Because I can tell you, as a radiation oncologist, people love, if you're a radiation oncologist and you specialize in prostate, it's a very rapid throughput. Because it takes me, I can contour prostate and seminal vesicles. I've done it so much I could do it in minutes. If I get a head and neck cancer, where I'm trying to decide, is this guy going to be swallowing in 10 years? Is this tumor? Is this not? It's an all-day affair. Well, guess who makes, the way they put it is RVUs. Who generates more income? The prostate guy. So if you're in a practice where what you generate is what you get paid, why would you want to be the prostate guy? In our setting at the university, we don't get reimbursed that way. Now that doesn't mean if we don't make money, it's got to come from somewhere. So it's not quite as incentivized, but it's still there. We still think about it. We still wonder how we're going to get paid. So again, these are the survivals. I'm going to see if we can get through these slides, and then I can start looking at you in the eye and start answering questions. Am I done? I guess I am. I thought I had another slide. So the last two slides I have were basically saying, well, so I think there was a couple of their studies basically saying that they calculated that the number of people that needed to have, so there's no overall survival difference at all 10 years. Everyone does the same. I think the overall number of deaths from prostate cancer were 8 in the non-treatment or the active surveillance, 5 and 4. So everyone was, and that was out of 500 patients. Everybody did very well. Everybody, if you looked at overall survival at 10 years, I think the overall death rate out of those, there were 59, 55, and 55. I mean, you really can't get numbers any closer than that, considering you're starting out with 550 people. They were identical.
Did they know what killed them anyway? Could have been something else.
Right. Well, and I'm just really mad that this isn't coming up. Oh, and there it is. So this is the other thing I tell my residents. I said, the only endpoint you cannot fake is survival. You're either alive or you're dead. If you look at cause of death, how do you know what kills somebody?
Autopsy.
How many autopsies are done in the United States percentage-wise of people that die? Probably less than 1%. You know why?
Too much money.
They aren't reimbursed. No one pays for them. And we think we are so smart that we have CAT scan. We know everything. We are so smart. We are so smug that we know what causes people to die. We don't. So this is, I found this is it's a very interesting article. But they had an independent cause of death committee. So if you need a committee to determine what killed a certain patient, it's not and you had definitely, probably, possibly, probably not, definitely not. So how solid is that endpoint? So you say, oh, there are more people that had, and then they said people were thought to have clinical progression based on evidence of metastasis, diagnosis of T3 or T4 disease, androgen deprivation, fistula obstruction. How did they determine who had metastasis? If your PSA went up beyond a certain point, you had a bone scan. 10. So who had the most bone scans? The people who were being observed because their PSAs naturally turned up. Who had the most hormonal treatment? The people who had their PSAs go. Now, did they need it? I don't know. If you take 500 guys and you do bone scans, you'll find one that's positive for absolutely no reason. So it's a soft endpoint. That's why it's important to follow these people out. You know, if that little bit that we think is real of people with metastatic disease based on what they chose, if that separates, then that's real. If it comes back together, you just have a little early diagnosis. And they say the purpose of active monitoring was to avoid overtreatment, but to monitor progression rather so radical treatment with cure and intent could be given as necessary. That is a line we do not know how to straddle. We don't know when to pull the trigger. Everyone has their own lines in the sand that they helps them sleep at night. Say, oh, if we're going to follow this till it gets to be 20, and then we got to do something. But those things aren't really proven. But when you're getting your PSA checked and you haven't been treated, and there's an option, there's this constant push. Why aren't you being treated? You know, they're constantly asking, do you want to be treated now? I mean, think about that. You have to be kind of resistant. Oh, it's prostate cancer, sure you don't want to be treated? That's a tough thing to do.
It comes from relatives also.
Oh, yeah.
Family.
It comes from spouses. It comes from doctors. It comes from anybody. So you just have to recognize that that's out there. You know, it's not a perfect world. You have to know what's influencing your decision. So androgen deprivation is offered when, I can tell you right now, if a guy's PSA gets to 10, I don't get bone scans. I mean, that is just that's what they did in the study. I don't do that. That, to me, is looking for false positives all over the place. Bone scans are like the hardest thing in the world to read. Androgen deprivation, you've got above 20. Is that the right time to do it? I don't know. We all know what androgen deprivation does. Makes your PSA go down, may fog your mind a little bit. If you got a sex life, it takes it away. You lose muscle mass. You know, when I see somebody that's 85 and they say, should I start on hormones? I said, you know, the biggest thing that's going to kill you is pneumonia or falling and breaking the hip. And the thing that'll help that along is taking away your testosterone. So just let it go. So again, these are the numbers I didn't think I could bring up before. But again, any cause of death, 59, 55, 55. I mean, this is such a statistical dead heat, it's unbelievable. But that's due to prostate cancer, even with that probably possibility. 8 active monitoring, 5 surgery, 4 radiation. Those are not significant, but you know, active monitoring does have to more than everybody else after 10 years. So and the other one that you look at is free of metastatic disease. This one is a little, this is 33, 13, 16. So either there was an early detection bias or this will play out, and if it's real, 10, 15, 20 years later, those curves will spread. So what does that tell you? If you have a 10-year life expectancy, why wouldn't you watch your prostate cancer? If this gets out 15 years, you know, if it gets out 20. So some people say, they think that the cure of prostate cancer is going to be, we're going to figure out early detection, there will be some genomic test, and they're out there. I don't believe them, but they're out there, and there are reasons to get treated. There's also, I was talking, before this talk, I went to Mike Lamba, who works with the MRI people that you see. And he is one of the smartest guys in the world. I'm so glad he's my physicist. And he worked with the diagnostic people on the endorectal MR and did all the special tests that they can do. And they said, oh, we can see all these beautiful pictures. And I went to him, I said, Mike, I know you got these beautiful pictures. How do you know what to do with anything with them? And he goes, oh, I don't know that. I'll ask you. I'll look it up for you. I get this email back this morning. It's Kevin. There is no data on how this affects your body. We're just gathering the pictures. And that's what you have to do. When you have a new modality, you have to look at it, but you're not going to have real data for 10 years. And this is very telling what he said. He goes, but I can tell you that if when I get my prostate cancer and I decide to follow it, I'm going to have this test done. Because he believes in what he's doing. Urologists believe in what they're doing. I believe in what I'm doing. But we've had people through the history of medicine believe in what they're doing and they've been wrong a lot of times. So you just have to keep an open mind. I don't want to tell anybody here what to do, but I'm saying it's not as clear cut as some people think. Yes, Tom?
How about the risk of malpractice? Is that a big thing in your practice? All these extra tests, all
I
that.
will tell you, and I don't want to be smug about it, but in the university setting, you get a little bit more protection because people assume, well, you know what you're doing. Could be totally, not true, but they think because you're at the university, oh. And so, but that's why I always will, I mean, as soon as this study came out, I discussed it with every new prostate cancer patient I see. I said, this is the best data I've ever had. And this is what it's telling me. So I want you to feel comfortable with your decision, but you need to know whatever you decide is probably not going to make a difference.
All right, since this was, most of these guys were quote-unquote low risk, right?
Mm-hmm.
All right, are there any studies out there? Because mine was a Gleason 9 and Johns Hopkins and
Mhm.
Gleason 10, so
So,
I had the radical
right,
prostate.
so we all know that's a different set. And I think everyone, radiation oncologists, surgeons, medical, everyone agrees that that's a trigger to treat. If you're in that high risk, there are no let's do nothing because everyone's scared to death to do it because no one believes that. I mean, so how do you sell that to a patient? You say, I wouldn't have that done to me. Wouldn't recommend that to my father. I used to say to my father, now it's me. I wouldn't do that for me. But the issue in there, I think, where there's a lot of debate is what's the best way to combine therapies? Are you better off having a radical prostatectomy, knowing that there's a 50% chance that you're going to need post-operative radiation? Are you better off having hormones and radiation together? Because that's what I would recommend if you said I'm not going to bother with surgery. Do we really know? Have we compared those head-to-head like this brilliant study did? We don't have that data. I'd love to have it. It would make my life so much easier. Because I could counsel patients better. Because that's, at the end of the day, that's what I'm paid to do. Yeah, I know how to run a proton machine. I know how to set up a prostate treatment. That's easy. I could teach all my residents to do that in 2 years, let alone 4 they stick around. It's taken me 30 years to get to this point in my life. I think I can say I've never been done. And the doctor you want to have is the doctor who knows what he doesn't know. So when you come out of residency, you think everything is written in stone. You memorize all these algorithms, how you're going to treat lung cancer, prostate cancer, breast cancer, and you're smart. You've got a memory. You can remember all that stuff. You can walk into the room, and then things change. Then you're at about 5 years, and you find out what you do about lung cancer is totally wrong. And you're like, well, that'll never happen again. And then you go on another 10 years, you find out, I thought I knew about that's not right either. So you are more certain of the error bars in your decision. You know you make the best decision you can, but you know there's a chance of being wrong on either side. That's a good position. So they can express that to you. And what patients don't, and I'm really going on, I apologize for it. But I think what patients don't or have trouble accepting is the concept of risk. They say, I don't want this. I said, that's too bad. You're going to get it. You can minimize the risk, but I can never tell you it's not there. Yeah.
There's now another MRI machine in Cincinnati, the one that you guys have at UC, and now urology group has one. So I know a couple men that decided to go with urology group for the second MRI.
Okay.
And the one downtown, or down in Clifton, it's pretty extensive. They, like you said, put the coil in. But they said that they just go in a tube, they lay there, and it's just like when you get your leg MRI. And I'm
It's a
thinking,
different study. I mean, it's,
how would that work just as good as, they said it's way
well,
more.
how do you define just as good?
That's what I'm asking you.
Well, I told you I couldn't. I told you that we're doing these studies and we don't know exactly what we're gonna do with the results.
So, I mean, they only pick, because they want you to be MRI every couple of years or something. So,
Gotta pay for the
but
machine.
after listening to you, maybe not.
Well, I think there's a lot of things out there. I've had people come in and say, what about this treatment? I said, how long have they been doing it? They said they have great results over a year. And I'm like, I don't need to read that study. I want long-term stuff.
So you don't know anything that you.
So I'm getting the hook. Like,
A bit about the parking tables. PRTIN.
the parking tables were designed to give people an idea of how much they needed to treat. So they were trying to give you percentages based on these factors: Gleason score, PSA, and they're not perfect numbers. The chances that your nose are going to be involved, the chance you would have extracapsular extension, so that you wouldn't go in and get a therapy and they say, "Oh, this is much worse than we thought." They're not perfect. We've been debating for just on the radiation oncology side whether it's good to treat nose and prostate cancer or not, and when. We've been debating it for as long as I've been in the business, and we don't know. So it's something that people like to hang their hat on, but take it for what they are.
Well, we keep hearing the term curable when doctors will tell you, I can cure your cancer now. And this was told to me by Dr. Stevens.
Yeah, and what I would say is depending on where you are on all these numbers, does your cancer need to be cured? That's the real question. You have something that we think is cancer, but its natural history is not a cancer. And that's always been the issue of prostate cancer. And there's no perfect guideline. There's no 100%. So you have to be willing to accept the treatment risk versus the non-treatment risk. And this data is just tools to help you decide and make a informed decision on treatment. Not your doctor. Yeah.
You have a rough, there are 26,120 deaths from prostate cancer each year, give or take.
Right.
Are they all coming? You know what percentage are coming from Gleason?
I don't know that data. I would assume that
Versus 8s, 9, and 10.
majority of them are 8 and 9s and 10s. But I know, if you look at any low risk group and the treatment and you follow them, there is a fall off. There are certain people that fail. Whenever that happens, we go back and we're like, did we miss a PSA? Did we miss the staging? Did we do something? Did we miss the not treat? We look for a reason why. We want to know why we failed. Why that 1 out of 10 failed. If we could hit that 1 out of 10, we would treat them very aggressively, and we would tell them that's the holy grail. We tell the 9 guys to go home, live your life, don't worry about it, don't ever guard your PSA again. But we need to do something special with you. We don't have that. It's based on what we know with very arbitrary and very crude measurements. Our PSAs, Gleason scores, how it feels, and there's another tier of peritoneal invasion, number of pores. But it's not perfect. It's just percentages. It's risking you out. And nothing is 100% and nothing is 0. Yes.
Basically, you were saying whichever treatment you decide, you have the same outcome. So basically, the treatment is basically meant to give you peace of mind or whatever you're most comfortable.
Well, that's one way of looking at it.
That's your.
No, that's one way of looking at it.
That's how you look at it.
But I'm not deciding on prostate cancer treatment. I'm telling you what your options are. Intervention.